5B. Okay, so we're going to be talking about the femur and the pelvis. Okay. Okay. So again, we talked about this part the last time. This time we're talking about the femur itself, the hip, and the pelvis. Okay. Okay, so when we were talking about the femur, we did mention some stuff at the top. Okay. Now, if you look at this, this is an anterior proximal femur. This is a posterior proximal femur. Very similar, but not exact. Okay. So this right here represents the greater trochanter. This is the lesser trochanter. Greater trochanter, lesser trochanter. Now, on the anterior image, we see something that connects these two things, and it's called the intertrochanteric line. Okay, not as prominent as what's posterior. And most people don't ask you this, but it is important to know in case you ever see it, okay, as far as in writing. So this would be the intertrochanteric line. Now, posteriorly, this is more important, more prominent. This would be the intertrochanteric crest. Now, I know it sounds like a big word, but intertrochanteric just means between the trochanters, okay? Now, this part is called the head of the femur. Under every head is a neck, okay? And if you look very closely on the head, there's a little area right here called the fovea capitis. The fovea capitis has a ligament attached to it that attaches it to the acetabulum. The acetabulum is the socket for the hip joint. Okay, so this is going to articulate with the acetabulum. And on this fovea capitis is a ligament that attaches it to that acetabulum, along, of course, with other ligaments and tendons and stuff. Okay, so in addition to the ligaments and tendons being much bigger and the acetabulum being much deeper, we also have that ligament that attaches it to the acetabulum, all of which the shoulder does not have. Okay, which is why it's so difficult to dislocate a hip and very easy to dislocate a shoulder. Okay. And that ligament is attached here at the fovea capitis, okay? Okay, so you can look at the various angles here, but remember I told you last time that this angle right here, okay, is what differentiates us from the great apes. The great apes, the angle is straight like this. They don't have an angle, okay? And so when they walk, they look kind of funny and goofy. And yes, we could pretend like we could walk like that, but it wouldn't last very long. And we for sure couldn't run for our life. So it's not a survival thing, not for them, because that doesn't work that well. For us, it does. You know, I mean, many humans have run marathons. Okay. Most animals cannot. We are probably the only one that can run that far. Okay. But it's because we have adapted, not totally, but we've adapted to bipedalism, and the great apes haven't. Okay, which is why when they walk, they look goofy. Okay. Okay, and also, I also mentioned last time the angle. The female has a greater angle than does a male. How come? Because the hips are wider and the knees have to come together for you to be stable. The knees have to come together, have to be a certain distance apart. And if it's like this, it's too much, especially if the hips are like this, the knees have to be together. Okay. on a male, then when their knees are together, okay, then the hips are still like this. It's not quite that straight, but it's much less, it's less angle on the male than the female, okay? Okay, so here we're looking at the pelvis, okay, and we see two hip bones. The other names for the hip bones are the ossa coxae and the innominate bones. You do need to know those names also, okay? This is the hip bone, this whole thing right here. Now, they used to be made of three parts. They weren't fused together yet. As an adult, they are fused together as each hip bone as one bone. It used to be three parts to each of the hip bones, okay? And also you'll see right here is the sacrum and the coccyx. These used to be separate bones also, which is why when you count the bones on an infant, they have more bones than we do because a lot of the bones haven't fused together yet. What we count as one as an adult were several when they were infants, okay? Okay, so these are the three parts to the hip bone. Okay, we have the ilium, which you see in green. You have the pubis, which you see in blue. And then you have the ischium, which you see in purple, okay? Now, this right here, and I didn't mention it to the last class, but you see this right here? This is called the ischial spine. Now, this should have been purple because it belongs to this bone. This is it right here, okay? It should have been purple, okay? So what the mistakes that this guy makes, I think can cause confusion, okay? But you know, you're looking, well, why would they call this the ischial spine? If it's blue, it should be the pubic spine, and it's not because he colored it wrong, okay? Okay, now this part right here, I said is the socket that fits the head of the femur to make the hip joint. Okay, so this socket right here that you see on the lateral, okay, you see a third is green, a third is purple, and a third is blue. So it kind of evenly divided the acetabulum made up of all three parts of the hip bone, okay? So again, the hip bone is made up of the ilium, the purple, the ischium, and the blue, the pubis. But they are fused in the adult, okay? They are fused in the adult. Now, and this should have been like right there, okay? Because this whole thing right here is the ischium. And you can see right here on the ischium, you see this part right here, okay? That's called the ischial tuberosity. That is what you're sitting on right now. I like to call it your butt bone, okay? The ischial tuberosity right here. And I said this was what? The ischial spine, okay? And again, that should have been purple there. Okay, so this is the ilium. Notice that the ilium, what is this thing across the top here called? Iliac crest, okay? Now, this ilium right here is spelled with an I. If you spell it with an E, it's wrong because that is part of the small intestines. Okay, so in this instance, if you misspell it, it's incorrect. Okay, so this is spelled with an I. It's easy to remember this because you know how to spell iliac crest, right? That has an I. This has an I. Okay, so this is the iliac crest. The end of the iliac crest anteriorly is the, do you know what that is? The ASIS. Remember the ASIS? Okay, this is the ASIS here. We said this was the acetabulum here. This is the ischial tuberosity. And this blue right here is the pubis. Okay, now in between the two pubi, right here, we have something called the symphysis pubis. The symphysis pubis. Now, this is cartilage in between here, and this can act as a shock absorber. Okay, it's cartilaginous and it can get squishy. Now, this is an this is an amphiarthrodial, meaning only slightly movable. Okay, and its movement is only during trauma or childbirth. Okay, the same thing right here. Okay, these right here, this is the sacrum. This is the ilium. Therefore, this joint is the sacroiliac joint. Okay, this is the sacroiliac joint right here. We talk about the sacroiliac joints more so in the next unit, which is the vertebrae. Okay. This joint right here moves only during trauma and childbirth. Okay, so both of these are very only slightly movable. This one less than this one. Okay, why childbirth? Yes, it can, because if the baby's head's too big, if the baby didn't come out, and of course during modern days it'd be a cesarean, but in the olden days they both die. Okay, so yes, this helps increase this right here. This is the pelvic brim or the pelvic inlet. Okay, and this has to be big enough to allow the baby's head to go through during childbirth. Okay, and this can separate a little. Okay, or trauma. Okay, let me give you guys an example. If this is, okay, if this is a circle, right? Okay, if this circle was made of glass and you bumped into the wall, it would crunch, wouldn't it? It would just, ow, it would crunch, literally. Okay, but if you had a cushion in there, okay, which is what this would be and some of this, if you had that cushion and you crashed into the wall, you see what would happen? It's a shock absorber. Okay, so because all of this is connected, okay, to prevent this circle from breaking, it has to give way somewhere when there's trauma. Okay, and so that's what these shock absorbers here deal with. Okay, all right. This right here is called the obturator foramen. Together they're called foramina. Those two are the largest foramina in the body. Where is the next largest? That's right. It's in the foramen magnum, the base of the skull, and that's where the spinal cord goes through. Okay. Okay, let's start off with the ilium. I-L-I-U-M. Okay, again, we have the iliac crest. It ends anteriorly in the ASIS. Now, it ends posteriorly in the PSIS. If this stands for anterior superior iliac spine, then this stands for posterior superior iliac spine. And if this is the posterior superior iliac spine, this is the posterior inferior iliac spine. So this is the PIIS. So again, if this is the PSIS, this is the PIIS. Okay. Okay. Now let's go over to this one. If this is the ASIS, then this is the anterior inferior iliac spine, which is the AIIS. Okay, so ASIS, PSIS, AIIS, PIIS. Okay, all right. He made this look like this sinks in. It doesn't. Okay, but this would be called the ala or the wing, this lower area of the body. Let's go to the neck. This would again would be the acetabulum. Okay, so let's see. Do you remember what is this right here? ASIS. Now, how do I know this is anterior? Because this is the pubic bone right here. This is where the other pubic bone meets it for the symphysis pubis, which is anterior. Okay. And this is what you sit on. So this has to be posterior because your butt's posterior, hopefully, right? Okay. All right. So this is the ASIS. This is the PSIS. This is the PSIS. This is the PIIS. If this is the PIIS, this is the AIIS. It's like a puzzle, huh? Isn't that fun? Okay. Okay, so let's move on down to the ischium, okay? I told you earlier, this is the ischial tuberosity, okay? This right here is the ramus of the ischium. Now, I'm going to move on right here. This is the inferior ramus of the pubis. This is the superior ramus of the pubis. And again, this is just the ramus of the ischium. What does ramus mean? It means like branches or arms. Okay? Something extending out from something. So plural is rami. Okay? So again, this is just the ramus of the ischium. This would be the inferior ramus of the pubis, superior ramus, try again, superior ramus of the pubis, okay? Okay, now look right, just a second, let me get a new color. Okay. Okay. Do you remember this last time? I said this is the ischial spine, right? Okay. Now, typically this is a little bit bigger in males than females. And that's a good thing. So the baby doesn't have all these grooves in their head. Okay. All right. Now, remember this is the PSIS, the PIIS. Okay. Under the PIIS is the greater sciatic notch. And on either side of the ischial spine, we said the greater sciatic notch and we have the lesser sciatic notch. Now you can pronounce this sciatic or you can pronounce it sciatic, kind of like sci in science or sky as in school. Okay, so either way is fine, but it refers back to the sciatic nerve. You guys heard of that? You have? Yeah, how have you heard of that? I can't hear you.
Pregnancy has a lot of issues with that.
How did you know that?
I have 2 kids.
Okay. I'm the only one that I ever heard of that had that problem. Okay, yes. Many males have the problem. That's usually where you hear about it, okay? And it's typically because of where they carry their wallet. Most men carry their wallet in their back pocket. The sciatic nerve runs along the back of your buttocks on the inside all the way down your leg, okay? So if you wear your wallet in your back pocket and you sit a lot or you wear pants that are too tight and it presses up against that sciatic nerve, then you can get, it can become inflamed or injured, okay? Usually men go to the doctor, I got this pain going down my leg all the time. Well, give me your wallet. Then you go, no.
Well, that explains a lot. I never wore pants. I always wear shorts. I never had that pain.
You know, but a lot of men do have that pain, okay? Especially if they sit all day, okay? Now, I've had it twice in my life. One was when I was pregnant, and the baby's head is pressed against that nerve, okay? And so bad that if when I was laying in bed at night, I literally had to turn, I had to lift my pants leg to lift my leg because it was dead. It was literally dead, okay? But a hot bath took care of that, okay? But usually what the doctors will tell men is a heating pad or ibuprofen or something like that, okay? The other time I had it, I was on a shoe shopping marathon. And when you're doing a marathon, you don't have time to sit down and enjoy the process. You have to run through all the stores and try on all the shoes. And I didn't even bother to sit down. I did it standing up. So I crossed my leg in front of me to put the shoes on. And I bent my leg in such a way that you don't normally do. And I did it a gazillion times in one day. So then I had a very, very painful sciatic nerve because of that. I didn't know I had one until then. Okay. So lots of times doing a repetitive motion that you don't usually do that involves bending that area can cause that also. Okay. So, you know, repetitive motion, a wallet in your back pocket, and pregnancy. Okay. But anyway, these are named after because of the proximity to the sciatic nerve. So this is the greater sciatic notch. This is the lesser sciatic notch. And this is the ischial spine in between. Okay. And yes, you have to know those. Okay. And what was this? You can't just say ramus. There's rami all over the body. The ramus of the ischium. There we go. Okay, so this is the pubic bone right here, or the pubis. Okay, this would be the symphysis pubis right here. Again, the obturator foramina on both sides. This is the body of the pubis. We said this was the superior ramus of the pubis. This is the inferior ramus of the pubis. Okay, again, arms or branches. So you know this is anterior because this is the pubic bone. Okay. Okay, and this is what we just talked about already. So this is the ASIS anteriorly and from a lateral view. This is the symphysis pubis anteriorly and here from a lateral view. These are the ischial tuberosities here, and here it is on the lateral view. Okay, this is the ischial spine from the front. This is the ischial spine from the side. Okay. Okay. This area that they have dotted in blue is called the brim of the pelvis or the pelvic inlet. The brim of the pelvis or the pelvic inlet. Now, above this brim right here is what we call the greater or false pelvis. Okay, so this sits, okay, at an angle. If you're looking at the pelvis from the front, it's going to be angled like that. Okay, and so above that would be the greater pelvis or the false pelvis. Below that brim would be the true pelvis or the lesser pelvis. Okay. Okay. Many years ago, we used to take x-rays of pregnant women. And one of the projections that we used to do was called a fetogram. Here would be an AP fetogram, and here would be a lateral. The main purpose of the fetogram is to see bone age, to see if the fetus is developing at the proper age that the numbers tell the doctor. Okay, so and they can tell the age from the bones. Okay, the development of the bones in the fetus. And I used to love doing these. Okay, what I didn't like doing was the pelvimetry. A pelvimetry is typically only taken from here down, and you had to use a pelvimetry ruler to help measure the pelvic inlet and the pelvic outlet to make sure that the baby's head would fit. Okay, that's of primary importance during childbirth, because not so much today. I mean, it's still important today, obviously, because they need to know whether they have to have a C-section or not if they're having a problem. But in the olden days, if the head didn't fit, they both died, both the mother and the baby. Okay. But anyway, so we used to do pelvimetries. We don't x-ray them anymore. Now they just do ultrasounds. Okay. So that they don't have to worry about the radiation. Okay, so how do you tell a male pelvis from a female pelvis? Okay, typically the female pelvis is wider compared to its length. Okay, with the male pelvis, it's typically narrower compared to its length. So a student in the earlier class, I thought that this was cute. On the female pelvis, it's like the butterfly. A butterfly has opened their wings. I thought, how poetic. Okay, just a second, okay, so the butterflies open their wings, okay? And the male pelvis, the wings are kind of getting closed. Okay, is that not poetic? How cute, put bones into a poem. Okay, so these wings on a female pelvis are like this. On a male pelvis, they're more like this. Okay, so it's the general shape. One is the wings are out, and these are called the wings or the ala. Okay, so they're like this or like this, female, male. Okay, this right here is the pelvic brim or pelvic inlet. Okay, this has a more rounder shape versus, this isn't a really good example, versus an oval shape. Okay, on the pelvic inlet. So the inlet is usually smaller on the male and more oval shape because it can be. Okay, now the other thing is right here, this is called the pubic arch right here. Okay, now this pubic arch on a female is typically greater than 90 degrees. On a male, it's typically less than 90 degrees. So less than 90 degrees makes it an acute angle. Greater than 90 degrees makes it an obtuse angle. See, geometry comes to life. Okay. Now, sometimes on female, sometimes you'll see this arch right here. It's like straight at 180 degrees. Okay. Another thing too is right. The reason why this looks shorter is because if you look at it from the side, the female, I'm probably exaggerating a little bit here. Okay, this is the sacrum, and the males would be more straight down. Because again, you don't want all these extra grooves in the baby's head. There has to be room here. Okay. Would you shut that door, please? Thank you. Okay, so here's a male pelvis and a female pelvis. Can you tell me which one's which? How can you tell? Okay, so on B, the wings of the ala are more like this, or the wings of the ilium, excuse me, are more like this, and the female is more like this, right? Okay, and look at this. That's, whoops, that's pretty nice and round. This one is more oval here. Okay. Also, okay, you can see right here, we have a very small pubic arch. And look at this one right here. This one's almost straight across. You see that? Okay. In addition to that, you have gonadal shielding, and you see a little photobomb by the penis right here. So that's obviously a guy. Okay. Now, what is wrong with the lady on the left? She always polka dots all over her. That's metastasized bone cancer. Okay. I'm not sure if this person lived very long after this. Okay. Now, sometimes bone cancer is a secondary cancer resulting from primary. Okay. Lots of times bone cancer comes from breast cancer that is metastasized. Also, breast cancer can metastasize into brain cancer, or all of them. Okay. But in this instance, well, not in this instance, but lots of times females with breast cancer don't die from breast cancer. They die from a broken neck. It happens. Okay. Do you remember when I showed you those vertebrae, especially the upper cervical? They're very, very tiny and they look very fragile. Okay. Now, if you look at this tumor, right, the size of this one, this is probably about the same size that a C1 would be. Okay. Remember C1's that circular one? Okay. And these, the bone framework is very small. So can you imagine one of these along one of these walls right here? Remember, these little fragile things are holding up your big old bowling ball head. Okay, weighs 8 to 10 pounds. So sometimes all it takes is you turn your head and your neck breaks and you die because it falls over. Okay, so lots of times, you may see bone cancer here, but it may have a bigger effect somewhere else, especially if it's in the spine. Or look right here, this all looks eaten up right here, all of this. Okay, see the difference between this side and that side? Okay, so, but anyway, this is metastatic bone cancer. Okay, male or female? Why do you say that so assured? Why? Yeah, at first what I see is like, wow, she could give birth to a 50-pound baby. Look at the size of that. That's huge. Okay, so that's a definite tell. This is definitely a female pelvis. Okay, and like you said, there's this, the pubic arch, and then these guys. That butterfly's got its wings really spread, doesn't it? Okay. Okay. Any questions, guys? No. Okay. Now let's talk about this positioning here. Okay, well, first of all, no, this is the acetabulum right here, okay? This right here, remember I told you that's a little space on the head? Okay, that's really rough for attachment for a ligament that attaches to the acetabulum. What is that little rough space right there called? a depression on the head, fovea capitis. That's what that means. Depression on the head, fovea capitis, okay? Now, positioning on a pelvis or hip involves positioning the feet. Now, why would I say the feet if, I mean, like I'm the wrong end of the lower extremities, aren't I? Because your feet are attached to your ankles are attached to your knees are attached to your hips. If you move one, everything moves, okay? So if these are your feet, you're looking at the soles of your patient's feet, okay? When you do this, what happens is it rotates everything all the way up to the hip. So that when you position an AP hip or an AP pelvis, you position the feet. And it rotates this. The whole idea is to get this neck of the femur parallel to the image receptor. That is a test question. It always will be, okay? So the purpose of rotating the feet medially 15 to 20 degrees is to get that neck parallel to the image receptor. Now, when you do that, and this one is not rotated quite far enough, but when you do that, you should get a beautiful U here, okay? We don't have a perfect U, but it's close. You should get a beautiful U shaped right here, okay? And then you should have a beautiful silhouette of the greater trochanter, okay? And then these guys kind of hide away. You probably shouldn't see too much of these. Like I said, they didn't quite rotate this far enough so you can still see it. This is the greater trochanter. These are the lesser trochanters. So depending on how these feet are, will determine what this looks like, what this looks like, what this looks like, and whether or not these are parallel to the image receptor, okay? Okay, so it's very important. A lot of people they do a hip or a pelvis and they just let the patient just flop there. Well, anybody could do that, okay? You're educated and you know that if you're going to do a hip, you have to get the neck of the femur parallel with the image receptor, and you do that by rotating the feet medially 15 to 20 degrees, okay? What is this right here? Hers sticks out a bunch. What is that? The ASIS, yes, okay. So the iliac crest ends anteriorly in the ASIS, okay. Now, this right here, just a second, let me get rid of all this stuff here. Go away. Okay. Now what was I doing? I'm so happy to erase. Oh, yes, thank you. Thank you. Okay, so this right here, this is the sacrum. Okay, this is the sacrum right here. Okay, and then down here you see the coccyx. Okay, again, we'll talk about the sacrum and coccyx when we talk about the vertebral spine. Okay, now if this is the sacrum and this is the ilium, okay, then that makes this right here the sacroiliac joint, which we'll talk about the SI joints again in the vertebral column, okay? So you can see right here. Now, most of the time, there was a line right there. There was a line right there, and people go, okay, there it is. Well, actually, it's the whole thing because these guys overlap, okay? So you see right there, parts the sacrum, parts the ilium, and they overlap. So just to say that this part right here is the joint. It's not, it's the whole thing right there because they overlap, okay? Okay, so here is a lateral femur, but it's done cross table, okay? And here you can see the head of the femur. Here's the neck of the femur. And if you look right here, all of this right here, that's the greater trochanter. Okay, now this can be done from medial to lateral or lateral to medial. It depends on how you can get your patient to do that. Now, here we have a cross table lateral. Okay. Now, the whole idea of this, first of all, let me tell you a couple of things. When you come in the program, you're going to buy a heavy duty 3-book set called Merrill's. That is the positioning Bible of the whole profession. Okay. And how they have this person positioned sends chills down my spine. They're on the 14th edition now, and they've been doing it since 1920. It's called Merrill's, okay? But what they do is they have this leg, the leg you're not interested in, they have this resting on the collimator and tube head while they make the exposure, because you gotta get it out of the way, may as well just put it on the machine. You never, ever, ever have the patient touch any part of the machinery during exposure. 1, because it can get hot, and 2, because of electrocution. Now, in the olden days, both of those happened a lot. Not so much anymore, but still, you never know, okay? So yeah, that stuff gets hot. You don't want to peel your patient off. I mean, you don't want him to leave worse than he came, right? So, so please don't ever, and I don't care what you see in your book, this should never be resting on the equipment. Okay, because remember, it's going sideways. And so where are you going to put that leg? I just rest it on the equipment. No, you don't do that. Okay. So, so anyway, so this is up and out of the way. This right here. Okay. You want the CR to go under this leg, and it's going to go through the neck. Okay. It's going to be perpendicular. I didn't quite do that. Perpendicular to the neck, and then be perpendicular to the image receptor. However, I told you this guy can't draw worth the crap. He doesn't have perspective, okay? And by looking at this, he's probably not a tech either. Because where is that imaging receptor located? Yeah, it's on top of the patient. Is that hip going to be on there? On the image receptor? No, there will be nothing on the image receptor. We're totally missing the part. This should be down on the table. Okay, so you can shoot through this and project it onto this. So the CR is going to be perpendicular to the neck of the femur and perpendicular to the image receptor, so that the image receptor and the neck of the femur will be parallel to each other. Okay. But it needs to be projected onto the cassette. And I'll show you what one looks like in real life in a little bit. Well, not real life, but photos. Okay. Okay. So anyway, so what we're looking at here is the cross table hip. Okay. So if you're the CR, this is what you're going to see. Okay. You see the acetabulum. You can see the hip joint, the head of the femur, the neck of the femur, and all of this, you're going to see the greater trochanter through there. Okay, can you kind of picture that? Because what you see as the CR is what you're going to see right here on the image. Okay. Okay, so on this one, you can kind of see a cross section of the sacrum and the ilium. And you can see that it's really kind of hard because you see this kind of curlicue in there. It's not a straight joint, okay? And on top of that, they're overlapping. So they're overlapping like this, and the idea is to get them open, but it's kind of hard when one of them is kind of like all crickety. Okay, but again, we will talk about SI joints in the next unit. Okay. Okay, so what about the joints? Okay, you've got two joints here. Those are the SI joints. This is, you have one symphysis pubis and you have two hip joints. Now, you also have where all of these bones come together and meet inside the acetabulum right there. That's also a joint because you have the three bones meeting in one place and they are joined. Now, remember, not all joints move. You better hope that one doesn't move. You don't want the head of the femur in a socket. That's every time you walk, it's all berserky. Okay. You want this acetabulum to be immobile, right? Immovable. Okay. And so it is. So it's cartilaginous, it's synarthrodial, it's immovable. Now the SI joints and the symphysis pubis, this and this, I told you, are amphiarthrodial, only slightly movable. The movement is limited and the movement only happens during trauma and childbirth. Okay. And the hip, of course, is ball and socket or spheroidal, diarthrodial. Okay. So we can move every which way. Okay. Now here we have a, they took it like it's a pelvis, but they didn't position the hips. So, and I see some barium here. So I'm kind of thinking that this may have been taken for something else. Okay. But this is really a kind of a messed up pelvis. Okay. So let's look at this. Okay. Now here you see the head, here you see the neck. And look at this beautiful U here. You see that? That's a beautiful U. Okay. Now, you shouldn't see too much of this, but let's look over here. This one was positioned like this. Actually, it's the right one. Okay. So that was positioned like this. This one was positioned like that. No, got to use the other hand. Okay. So, okay, this is the right side, which is right here. Okay, this is the left side. So got to do this backwards. So my right side is going to be like this. My left side is like this. That's how this person is positioned. Okay, this one is correct. This one isn't, if this was done for a pelvis. Okay, so the idea of, so on this one, the right neck or the neck of the right hip, okay, is going to be parallel to the image receptor. This one isn't. Okay, so you can see this is the greater trochanter right there. Okay, superimposed over the neck. This is the lesser. Look how huge that is. Okay, so lots of times with this one, lots of times you don't see this when it's positioned correctly like this is. Okay, sometimes it's just barely hiding right there. Okay, and then sometimes if it's like this, then you'll see a V. You'll see a V right here instead of the nice U, and you'll see a little bit more of this. And then when it's out this way, okay, because this is positioned inward, it's a medial rotation. This is just neutral, and this is an external rotation or lateral rotation. Okay, so this is the one where it's like this, and this one, it's positioned like this. Okay, right. Can you guys see the difference in these two? I like this one. Okay, now the title on this one says that this is anatomic position and just anatomic position. This is not an AP hip. Okay, this is just anatomic position, which means that your feet are straight forward, correct? So that your feet are going to be standing like this. Your feet are straight forward. So what that means is that this is going to have a V there, and you see a little more of this than you would if that was a U. Okay, see, this is a V, not a U. So that means that these are not parallel. And we see half of the lesser trochanter. Okay, who's confused? Anybody at home confused? Okay. Ah, shoot. Darn it. I better shut up. Okay, let me get out of this. Okay. Here we go. Okay, now, all right. Now, first of all, this is like way too far in. Okay, this is supposed to be 15 to 20 degrees. So they got a little carried away. Okay, but what this is supposed to give you is a U. Okay, and you probably won't see much of the lesser trochanter. So he drew this wrong. Over here, this is an external rotation, and this will be kind of superimposed, okay? And this it should look pretty big, and it does. Okay, so this goes with this, but this part does not go with this. This does, but this doesn't, because you should be able to see a nice U and a beautiful silhouette of the greater trochanter. Okay. Okay. This is just with the anatomic position. Okay. So with anatomic position, the feet are straight forward, and this is what you would see. Okay. This is not parallel, and you don't see, there's some of this person's pretty skinny, so that's why this is kind of blacked out. Okay. You don't see the outline real well of this because of the way they're positioned. Okay, because the feet are straight up, and you see half of the lesser trochanters. Okay. Now on this one with external rotation, this is exactly what you should be getting. Okay. So this does relate to this, except this is male. You can tell by the feet, and this is female. You can tell by the size of the pelvis. Okay. This is the first time I noticed this. You see this? Yeah, let me make that bigger because this is cool. Come on. Whoa. Can't believe I didn't notice that before. That just slaps you in the face. Okay. See, when they put arrows, your eyes go to the arrows, and you don't see the rest of what you should be looking at. Okay. But yeah, that's broken, and you can see right here. Let me go to this, and you can see right here. You see how it's kind of like it broke like this. Okay, so you've got this top layer here, then you have this bottom layer right here. So this is pretty sharp, I'm sure, right there. Okay, you see how it's just kind of split? Okay. Oh, wow, that hurts. When I was young and stupid, I can tell you now because they don't know who I am. when I was young and stupid, I did a trauma pelvis. They shouldn't have brought her into the X-ray department. We should have done a portable in the ER. Okay. And this was at Beaumont. This was a long time ago. And I was there by myself. And there was a husband and a wife on a stretcher and a little girl, probably about 10. Okay. Well, I need to get her on the table. I assume since they brought her there, she wasn't that bad off. Okay. Remember, I'm young and stupid. I'm probably 18 or 19. Am I 18 or 19 here? Okay. Yeah. Well, you're not young and stupid like I was. You're young, but not stupid. Okay. So I couldn't get anybody to help. I was there by myself, me and a little girl. So I needed to move her on the table. I wanted to move her on the table because she couldn't have been that bad. They brought her to the clinic. Okay. So I had the little girl help me. Never, ever, ever do that. Okay. When you come to the program, I'm going to tell you all the stupid stuff that I did. Okay. And if it was today, I'd never made it past my 18th birthday. Okay. So I had the little girl help me. Well, I could carry her. I took the heavy part. Okay. Why couldn't that little girl take the light part? So stupid. So we tried to move her with the sheet. Okay. And then when I realized we got her off of the litter, well, the litter moved. The litter moved. So we figured, well, let's put her back on the litter. Well, we couldn't because the litter kept moving and the little girl couldn't lift her high enough. So where do you think we put her? Now, luckily we didn't drop her on the floor, but we put her on the floor. Now, can you imagine when the husband comes in the room and his wife's laying on the floor? Can you imagine? That was one of the many stupid things that I did. Okay. And as it turned out, her pelvis was broken in like 5 places. Okay. You know, again, she shouldn't have been sent there. Okay. Because, you know, what do you do when you have a pelvis? Okay. You're going to have to lift them up and put on the table, or I could have put the cassette under her, but she couldn't have been that bad off because they sent her to me. You see what my rationing was? Okay. So that rationing wasn't so bad, but having the little girl help me was pretty stupid. Okay. No, she didn't get hurt anymore by having to lay on the floor. But the thing is that, you know, you always assume the worst. And that way, if it's not, then you're fine. Okay. You know, having a pelvis broken isn't that, I don't say it isn't common because it is common, but you don't get that many of them in the X-ray department. You usually have to go to the emergency room because it's a trauma. Okay. And usually it's a bad trauma like a car accident or something. So you usually go to the emergency room to do it. They don't come to you. Usually when you have something come to you, your patients can do everything. So, but don't ever assume that. Don't ever assume that. Okay. I forgot about that until I saw this broken pelvis. Okay. They put her back together. She was fine. But if I met her today, I would hide. I'm so embarrassed. Oh my gosh. Okay. Where are we? Right here. Okay. So go to the next one. Okay. Now here is a, okay, here is what a, how an AP hip or an AP pelvis needs to be positioned. Okay. And this is the correct amount. It's not the 45 degrees like they had said earlier, okay? So this is 15 to 20 degrees medial rotation. So here you can see we have a pretty close to a U, not perfect, but we have pretty close to a U here, okay? And you just see very little of the lesser trochanter. That means that even though this is what we're looking to see to prove that this is parallel, this is the whole idea of what we're doing, why we're doing it, is to get the neck of the femur parallel to the image receptor. Okay, to get the neck of the femur parallel to the image receptor. Oh, come on. Okay. The depression or pit located at the center of the femoral head is the fovea capitis, right? Which of the bones of the pelvic girdle is the largest? The ilium, the ischium, or the pubis? The ilium, right? Spelled with an I. Which of the following bony landmarks is located posterior to the acetabulum? This is kind of a stupid question for two reasons. I'm sorry, go ahead. Okay, the ischial tuberosity is posterior, but it's also inferior. And I would say it's more inferior than posterior. So this is the answer right here. This is not it. Iliac crest is way superior. And the ischial spine, it's kind of like in the middle. So this would be the best answer, even though it's not a good answer, because the question is not good. Which of the following bony landmarks do we use the ischial tuberosity or the ischial spine, for that matter, as a landmark? No, landmarks are things that we can palpate. Can we palpate either of those? No. Okay, so just kind of forget this one. Just mark this one off. Okay, not a good question or choice of answers. So, okay, the false pelvis forms the birth canal in females. Earlier, I answered it wrong because I was thinking false pelvis. Got it mixed up with true false in the false pelvis. The false pelvis is where? Is it above or below the brim? Above the brim. So does that form the birth canal? No, it does not. So this is false. False. Okay. This is a thinking question. Okay. Okay, the pubic arch of the male pelvis forms an acute angle. True or false? True. Okay. What is the joint classification of the symphysis pubis? Amphiarthroidal. So it's only partially movable and only under certain circumstances. What are those circumstances? Trauma and childbirth, right? Okay. Which bony landmark should not be visible on a correctly positioned AP pelvis? The lesser. Again, that's not a bony landmark because we can't palpate. Well, you're not going to palpate between their legs. Okay. So, and it would be really hard to, even if you tried, okay? So I don't like this question. I would just say, what bony protuberance would not be visible, okay? Because that makes it sound like you can palpate it and you can't. Okay, so positioning. Again, remember that you guys are not here to learn positioning, but to be able to relate an image and how it was positioned, okay? So here we're looking at an AP femur. And in this instance, we will be including the knee. Okay, so the femur is long. It's gonna be hard to put it on all at once, and it'll have to be done with the image receptor in the bucky because it needs to use a grid. So you're probably, unless they're tiny, not going to be able to include both joints, but you would include the joint closest to injury. So more than likely you would be doing including a knee, okay? Whoops, come on. Okay, so here you can see a femur with a knee in it, okay? And that looks fine. Okay, now here is a lateral femur. This one is including a knee, okay? So this would be considered a distal femur. Now, whenever you include a lateral knee, okay, this bothers the heck out of me. Okay, this knee should be 45 degrees. It's 90. Okay. So this should be coming down straight and this should be 45 degrees. That's how you do a lateral knee. Okay. But the rest of it is fine. Notice that they have a radiolucent sponge to hold this leg up out of the back and out of the way. Now, you may also move this way to the front, depending on your patient, if they can do that. Okay, but again, it depends on your patient. Okay. Okay, here is a cross table lateral medial. Cross table lateral medial. Can you picture that? So the cassette, they've built the leg up. The cassette is standing, and here's her other leg over here. Okay, and she's probably got the legs close together to hold this up, unless they put a cassette holder in there. Okay, so but this would be a lateral medial. It can also be done the other way, as this one was. This is the medial lateral. Okay. It depends, a patient may not be able to do this. If they're hurt, they may not be able to do this. This might be easier on them, okay? Okay, so this is totally blacked out right here. That's where the patella would be. Now notice how this is positioned properly. Well, that was a lousy straight line, but that's supposed to be 45 degrees, okay? And you remember I told you that should be 45 degrees, huh? Okay, so I'm going to write a letter to these guys. I'm going to send them a book back with everything marked off. Okay, so now here is a lateral proximal femur. Okay, so here you can see they've included the hip. Okay, now this right here is the head of the femur, and this right here, you can see it right there, that would be the greater trochanter. Okay. Okay, just a regular AP pelvis. Okay. got an AP pelvis, and you've got the both feet rotated medially. Okay, so CR between the ASIS and the symphysis pubis. Forget about this one. Don't worry about that one. Okay, here's you see that the lesser trochanters you don't see very much. You've got a U shape here, okay, which means that the neck of the femurs are parallel to the image receptor. Okay, is this male or female? Definitely female. Okay. Okay, now this is something called a frog leg or axiolateral. I like to call them frog legs. This right here, this is a lead shield for the gonads. I hate using these because when people use them, they misuse them. Okay, when you do a pelvis, you really do need to include the sacrum on the image. Okay, because lots of times if the pelvis is hurt, the sacrum might be hurt also because it's part of that circle. Okay, so if one thing gets hurt, another thing might get hurt also, and that other thing might be the sacrum. Okay, so now this says abduct the femur 45 degrees. First of all, that's not 45 degrees. Okay, and so let's talk about this first. Okay, now when you get somebody on the table like that, okay, they're starting off and their legs are like this, and you have them move their legs outward. Okay, so they're moving. These aren't feet. These are the legs. These are the femurs now. Okay, they're femurs now. Okay, so you start out this way. I can't do it that way. Sorry. Okay, so you have them move their legs out. Okay. Now, for a lot of people, as far as they can go, and once you walk away, they're going to start going like this. Okay, but let me give you guys a secret. If you put a sponge or a pillow on either side, on both sides, not on both sides of this leg, but on the other side of her and this side of her. Okay, if you put pillows there or a sponge, you build it up, and then you tell her, okay, go ahead and relax your legs on this. They're going to go, fuck. You have to try it on yourself. Lay in bed, and then spread your legs. Okay, oh, that's as far as I can go. Put a pillow there, go. As you know, so really, as long as they know there's something there to catch them, and they'll be comfortable, they can do that. Oh, now you're obviously not going to do it because you could hurt them. They have to do it themselves. Okay, but if you give them something to lay it on, they can. Most people can do it. Okay, they think, oh, this is as far as I can go. Give them a pillow. That's what I've discovered. Okay, so if you buttress them, then they'll move their legs out, and you'll get beautiful laterals. Okay, but this is called a frog leg or an axiolateral. Okay. Okay, what comes after? Oh, okay. Remember the shield I was telling you about? Oh, that's so perfectly placed. Isn't that wonderful? Okay. Let me have the pen before I get dramatic. Just a minute. Pen. Okay. This is supposed to be a gonadal shield for a female. Okay. Number one, they covered up the sacrum, right? Okay. Here's the ovaries. What did you protect? And there's so much scatter there anyway. Okay, so I'm not a believer of doing this on a female pelvis. Okay, and more than likely, this is going to cover up the areas that you want to see. So I would forego this. Okay, I'm not a believer on this for females, and now we don't do it anyway. Okay, now let's look at this is a frog leg. Okay, now, isn't this way more out than that girl was doing? She was like, it's not gonna do. Okay, but if you give them something to lay on, this is an older person here, give them something to lay on, and all of a sudden those legs just go. Okay, they're happy to be resting to the side. Okay, so, but look at this. Okay, this is really nice frog leg. Okay, there's the head. And look, you can see the greater trochanter there. It's beautiful. Both sides are perfect. Okay. But again, if it was this one right here, okay, that one, these legs right here would be about like this. So much for a frog. Okay. Unilateral just means you do one at a time, but you still have to do this, okay, with the feet. So here's a unilateral. You can tell this bone's old, okay. This one, okay, got the U shape. You don't see this, but you got the jagged bone. Okay, now here is a cross table that is positioned. Now, I don't know about this part because I'm seeing some stuff up here. So I'm not sure if this leg's resting on anything. Okay, but this is on the table. Okay, so you can see now if you shoot through this, you'll get this on the image receptor. Whereas the other one, it was sitting up here. So if it's sitting up here, how are you going to get this right here? You're not. Okay, you will have totally missed it. Okay. Oh, there it is. Oh my gosh. Okay, this one has a prosthesis in it. This is a hip replacement. Okay, so this would be the acetabulum. This would be the head. You can see where they removed the entire proximal femur on this one. Okay. Oops. Shoot. It's a good thing I'm saying nice things. Okay. Did we do this one? Okay, this one says, identify an obvious, repeatable positioning error. In other words, an error so bad that it has to be repeated. Okay, it looks like a pelvis, right? What's wrong with it? Anybody? This is supposed to be an AP pelvis. Exactly. This should be parallel to the image receptor, and it's not, because look, we don't look at this. This is like, there's no U there. Look at this. This whole thing is like superimposed over the head of the femur. Okay, and we see these huge lesser trochanters. So this was positioned like this. In other words, it wasn't positioned. Okay, you have somebody who didn't know what they were doing, lay the patient, take a picture without positioning the patient. Okay. Okay, where's the CR center for the AP pelvis? Number C, correct, or letter C. How is the cassette aligned for an axiolateral or Donnellus? I think it's a Donnellus Mueller, M-U-E, but anyway. That was that cross table, remember? that cross table hip? How is the cassette aligned? Parallel, I'm sorry, where is it? Parallel to the femoral neck, yes, okay. The end. Okay, guys, let me get all you guys. Okay, next Monday and Wednesday, you have to be here. Okay, how many of you guys do I have? I have 5 here. 1, 2, 3, 4, 5, 6, 7. I have 7. We'll just have to deal with it. Okay, if everybody wears a mask, we'll be fine. Okay, and all you guys have masks on. I'm not, because you won't understand me. Okay, so I will see. Okay, it'll be normal this Wednesday. Okay, you guys switching places. We will start vertebral column on Wednesday, maybe finish it, I don't know. And then next Tuesday, excuse me, next Monday and next Wednesday, you guys will be here, and we might have 1 test, we might have 2 tests next week, okay? Okay. Okay, any questions, guys? No? Okay. Then I will see you guys on Wednesday, okay? You guys at home and you guys here, okay? All right, take care, guys. Bye.